Good morning. It's a pleasure to be here. I'd like to discuss with you the techniques and the access to the wrist. So we'll go over the portals so you can actually get into the joint. My previous colleague already did the hard work of explaining the complicated anatomy. So for me, it's relatively easy to tell you some ways to get into the joint. And I'm from the Netherlands, and I'd like to show you with this presentation that we know a little bit more about wrist arthroscopy, other than, of course, know about cheese and clogs. Disclosure. So just a little brief introduction. Why would we do arthroscopy? Again, like Professor Montonin already said, it's minimally invasive. And I would encourage you to also treat it as minimally invasive, so be gentle to introduce your instruments. You can do it in a regional anesthesia. Of course, an important factor is that you magnify the image. The scope will magnify your image. You can actually see multiple joints in one session, which is a great advantage. You can do this day surgery, but the important is you can not only see, but you can also treat, and that's going to be in the course later on. You'll see what you can do other than looking into the wrist. So very basic. You need to have a setup with some traction. You need to. It doesn't matter if it's this type of traction. You need a setup that you actually distract the wrist a little bit. And of course, you need to have a counterweight, and it could be done through a fancy system, but you can also use counterweights. So you have a setup like this, patients in the supine position. This is an old-fashioned slide. You'll be on one side, and you'll be looking at your instruments on the other side. It's important that you have enough traction, but also that you have a good access to the wrist. Because if you want to do more than just look, you need to be able to insert all your instruments to get done what you want to do. Very basic again. What do you need? You need a scope, and you have to realize that the arthroscope is usually in an angle. It's usually 30 degrees. And I would encourage you, when we go to the session later on, insert your scope outside the wrist. Just see if you move the scope what your image does, because again, it's important to align your camera, and also to realize that you're looking under usually a 30-degree angle, and you need to realize that when you're scoping, and it's better to do that outside the wrist to identify which direction the camera moves than inside the wrist, because you may be confused doing that. Like I said, you need some traction with beautiful equipment later on that you will see. You start with the traction, and then you have some basic instruments. Usually this is the rough figure. You need at least 1.5 times the arm in weight, and you need additional instruments to get going. Which joint can we scope? Of course, my colleague already has mentioned we can do the radiocarpal joint, we can do the midcarpal joint. You can go up here to CMC1. You can go to the distal radial ulnar joint, and later on I will show you some examples of the small joints. Before you start, it's important to identify landmarks, and that this is the landmarks I think will be helpful for you to identify before you make your drawing and before you insert your scope. So you look at the radial styloid, you look at the dorsal lip. The tubercle is very easily palpable, very important for your 3-4 scope. Ulnar styloid, the base of the second and third metacarpal. If you can try to palpate your extensor tendons. This doesn't apply as much to cadavers, but in patients I like to mark the dorsal veins. So when you insert your instruments, you don't go through a vein and you have massive bleeding and you don't see anything for a while. So it's easy to, if the hand is still in supine, mark the veins, because when it's elevated, you will not see the veins because they will empty. So it's important. I like to make a vertical skin incision just because I'm always worried about cutaneous neuromas. And again, like Professor Montonin said, you will use I usually like to use a straight mosquito that you will use to insert into the wrist. I think a good trick also is, once you have opened the capsule, just keep the mosquito open just for a little while, because it actually will distract the capsule a little bit, and once you bring your portal in, you don't really have to go through this capsule again. So you just keep it open, and it will allow you easy access. It's important, if you go to the radial carpal joint, that you know there's an inclination, so you don't go straight down, but you go with a little inclination. And of course, for mid-carpal and the other joints, it's usually straight down, but it's something to keep in mind. The most used portals are mentioned here. Again, you see here the veins are marked, ECU is marked. So again, if we go through the portal, the most common portal is the 3-4 portal, and you palpate the listus tubercle. And about 1 centimeter distal, you feel a little soft spot, and that's where you make your mark. That's where you're going to enter through your 3-4 portal. Then it's easy. You go at almost the same length towards the other side, and you feel your extensor carpi ulnaris, and that's where your 6R portal will be. Your 1-2 portal will be on the other side. You just go with the curve of the radius, and you will go to the other side of the EPL. And again, the 6U portal will be on the other side of the extensor carpi ulnaris. So once we've established these portals, from there on it's easier to actually define your mid-carpal portals, because you've made your real mark here for 3-4. And the mid-carpal radial will be just 1 centimeter distal, this will apply 1 centimeter distal to the 6R portal, will be your ulnar mid-carpal portal. So then you will insert your scope. The STT is a little harder to do, because there's a lot of important structures when you insert. So it's usually easier once you already establish your radial mid-carpal portal, because you will see the inclination of the scaphoid, and you go about 1 centimeter radial, centimeter distal, and you'll feel soft spot again, and that's where you go for your STT. But again, it's usually easier once you've made your radial mid-carpal portal. And so why are we telling all this? It's very busy with tendons and some cutaneous nerves and veins, and even here a dorsal branch of the radial artery. What you want to do, you want to be minimally invasive. It means you need to slide exactly through all these important structures. That's why these portals were created. Is that you go through the 3-4 portal, you will go in between the 4th and the 3rd extensor compartment. And again, before you do that, you can always bring a little needle in. You identify the joint, and then use your mosquito and slide in. So it's important to realize that these portals are based upon intervals between extensor compartments, and also to avoid important structures. Again, I'll show you an example of a view from a 3-4 portal, and it's actually a patient who has some pathology, but he already has a scapholunate dissociation. And if you look for a mid-carpal portal, the bad thing is that you fall right into the scapholunate dissociation. But you'll see that you will be really on top of the structures where you want